Wow. I thought I was coming just to give a talk on osteotomy. That's quite the reception and incredibly humbling. So thank you so much, and thank you for that recognition. It really does mean a lot in front of so many friends and so many dignitaries and so many very special people. So I thank you for allowing me to take some time to share an area that is of great interest to me around osteotomy and share some of the research that we do. These are my disclosures. So I want to start by thanking my good friends here at the Pune Knee Congress, and to all of our friends from India and our colleagues from India. We have a very strong relationship, and Sachin and Parag have been good friends for a very long time. I was last at this meeting in 2016 where I brought my daughter. We traveled around this wonderful country, met lots of amazing people, and we've had many fellows from India over the time. These are just 10 of the ones that we've had, and many observers. So we have a wonderful relationship with India on an academic level, and also on the sporting fields we have a wonderful relationship as well. We're all looking forward to renewing that battle, I think, in about a month or two. So if we look at scientific advances that happened in my lifetime, which is just over 50 years, we've gone from a situation where to get computing power it needed to be all in this huge room in one building is now in the palm of our hands. Incredible technological advances in science. We've mapped the human genome. We've used that to cure diseases that used to be a death sentence. Modern anesthetics are amazing at what we can do to people when they're still half awake. And of course, we've seen diseases appear, and 12 months later, they've developed a vaccine. There's huge advances in science that have happened during our lifetime. If we look at the advances in knee surgery, arthroscopy is an obvious one, and robotics and other technology that we use to do our surgery more precisely, more predictably, and hopefully get better outcomes. However, the fact that we're still doing knee replacements means we haven't really solved the issue of osteoarthritis. We haven't worked out how to cure it, treat it properly, reverse it, or preserve the knee in every case. So there's still a long way to go. And if you look at how we make advances in science, so we can have experience, we can pass things down from generation to generation. That's sort of how we maintain the level of education. We can have collaborations and meeting where we can all come up to the level of the experts, so we bring people up that level. But if we want to go beyond that level, that's when we need science, we need research, we need good data, we need follow-up. And it's even no matter how good we think we're doing, we've seen some amazing surgery, amazing results here today. No matter how good we think we're doing, we need to question what we're doing and see if we can make things better. So on that note, how can science improve osteotomy? And this has been a great education for me as well in osteotomy, the things I've seen here today already. But it's an operation that's based on intuition. You have a patient like this person, they've got a varus alignment, they complain of pain in this spot, which is right where their weight goes through. So if we shift the weight across to this side, it makes sense that they would have less pain and they'd be happier. And this was published, this is even before I was born, so it's not a new concept, but once we have something based on intuition, we then need to move towards experience and evidence. And generally, the outcomes of osteotomy, in my experience, is that they're well. If the surgery is done well and the patients are selected well, this is the same patient. She's an ex-Olympic skier. She's 42 years of age. An X-ray that would normally get a knee replacement in most places around the world. We did an osteotomy. She's young. She's back to skiing. And of course, this is an example of someone who's very high functioning, very motivated. They don't all turn out like this. But this is an operation that reduces pain, it improves the function, and it preserves the knee joint. However, it's always been the poorer cousin to joint replacement. Why is that? Well, of course, there's narrower indications. We can't do an osteotomy on tricompartmental disease or really severe stiffness and deformity. But also, there's less research and development around osteotomy, largely because there's less return on your investment. Okay, arthroplasty makes a lot more money, and therefore there's less science. So if we have greater investment in scientific investigation, we can optimise this procedure. And this argument goes for all of these joint-preserving procedures. So how can science improve osteotomy? I just want to break this down into different areas where I think it can help us. So patient selection, preoperative assessment and planning, surgical technique, regenerative technology, and the post-operative management of the patients and ongoing data collection. I want to just touch on all of these areas. So if we look at patient selection, which to me is really the value of follow-up, because if we operate on people, we obviously think it's a good idea. If we don't follow them up beyond sort of 6 months, we don't actually really know if it turned out to be a good idea. So our indications for osteotomy now, most commonly arthritis in the young, active patient, meniscal deficiency, chondral pathology when the alignment is unfavourable. Same goes for instability, if the alignment's going to compromise your soft tissue reconstruction. Unusual cases, someone who's got severe genu varum, they've got chronic stress fractures, we make the leg straight, it relieves the symptoms, and then overload, like that in that stress fracture case, and then deformity correction. So there's many indications for osteotomy, but most of our experience is in using it for osteoarthritis, which is most of where our research has been. If you look at previous data, then to achieve best longer-term outcomes, patients who are a lower age, have a lower BMI, have a good range of movements, have lower arthritis grading and a well-preserved lateral compartment, get better longevity of their procedures. This is an argument for earlier intervention. The problem is often people don't turn up in those early stages. So this is our database. We've got about 550 patients in our database, predominantly opening wedge osteotomies on the medial side, but a smattering of other different types of osteotomies. And if we focus in on the medial open wedge osteotomies, we have about 432 patients, the average age 49, BMI slightly higher than ideal, and predominantly male. We've got an average follow-up of 8 years, but out to 19 years, and the average correction from 5.5 degrees of varus to 2.5 degrees of valgus. So fairly standard sort of cohort that you'll see. And these are our KOOS scores. So across every domain of the KOOS score, you see a statistically significant improvement. Same goes for the IKDC and the WOMAC, but not so much the TEGNA. It's not significant, but still improved. And this is our KOOS scores over time. So people will say osteotomy only by you 3 or 4 years. If you look here, this goes out to 15 years. And sure, they go up initially and then they go down a little bit, but from the pre-op to the 15-year mark, they still remain statistically significantly increased. So again, the procedure can be sustained over a longer period of time. And we get very similar results, but lesser number of patients in our distal femoral osteotomies. This is an important slide for managing expectations. The green is the pre-op, the blue is the post-op, significant improvements in each domain. The grey are age-matched norms, so people who are the same age, same activity level, don't have arthritis. So we can show from that people, and we can tell them you're going to get better, but you're not going to be normal. Okay, so we're going to make you better for a longer period of time, but you're not going to be normal. So this is useful for managing patients' expectations. If you look at our survival, then we have almost 100% at 5 years, but it drops to about 80% at 10 years. This is some of our older data, and I'm pretty sure that if we take out the patients who are poor candidates, and you choose them better, then you can get about 90% or more at 10 years. These are patients who've been converted to total knee replacements, and in general, they are older patients. They don't have a higher BMI in this cohort, and they're not more commonly male or female. They usually have a bigger deformity to start with, and they've had a bigger correction. And preoperatively, they have worse PROMs. So again, people who are a little bit older and have worse disease. And that's how you can sort of look at these patients and maybe select better patients for this procedure. If we look at the cartilage grading in their joint preoperatively, the ones who've been converted to total knee replacements have higher cartilage grades, particularly in the medial compartment, but to some extent in the patellofemoral compartment. So just summing that up, the patient factors that can compromise your outcomes when you're doing osteotomy are high grades of arthritis, larger deformities, worse preoperative PROMs, people who are overweight and who are stiff. So if we're trying to choose the ideal patient, and I understand that we've got a case today which is not going to be an ideal patient, but is probably going to try to choose the best procedure for them, they have localized pathology and symptoms. They've got mild to moderate arthritis rather than really severe disease, minimal stiffness, a healthy weight, they can't be smokers for this operation, and they have to have appropriate expectations as to what we can achieve for them. So I'm going to move on to preoperative assessment and planning now. This is the area that we do quite a lot of research in. So how do we measure alignment? So currently we're doing these scans called EOS scans, which are low-dose AP and lateral x-rays, full-length films. This is where we get our alignment measurements from. But there's limitations of radiology. They're static films, and they're very much two-dimensional. So we do this all the time when we're looking at x-rays. We're converting a 2D picture into a 3D image in our mind. And they don't incorporate dynamic alignment, patient-specific anatomy. So there are alternative ways to assess alignment. So we use gait analysis. We do it pre- and post-operatively on all of our patients. And it's not replacing imaging, it's just a supplement to the imaging. And for a large extent, it's a bit of a research tool for us as well. So our patients will go through the gait lab. They do modelling of all their muscle forces. We can measure their forces across their knee, pre- and post-operatively. We can model the knee and we can look at the joint surface and say exactly the force on either side of the knee, pre- and post-operatively. And then we can use that and look back and see what gave us the better results. So again, it's that sort of iterative feedback. These are the last 40 patients put to the gait lab with medial compartment disease, and you'll see the adductor moment, which is the force across the medial side of the knee, drops to a more normal level. And with a distal femoral osteotomy, we obviously take them the other direction. And so all of our patients get this. We can see what we've done with our correction. We have an X-ray showing the alignment. We can have the forces across their knee joint, and we can correlate that to their outcomes. And we know that when we're doing this, what we're trying to reduce is this adductor moment from very abnormal to very much closer to normal, even a little bit beyond normal. And we know that we achieve this if we correct them to about 2 to 3 degrees of mechanical valgus using navigation, which we've used for many years. Now, if we think about that a little bit further, your HTO reduces that adductor moment, the force across the knee, by reducing the moment arm, which if you see here is that little red line from the centre of gravity across to the centre of the knee joint. And when they're post-operative, that moment arm has been reduced. So can we measure this on a long leg film? Well, we can. We can take the midpoint between the hip joints, draw it down to the ankle, measure that moment arm there. And so we looked at that and we compared how well that correlates to the adductor moment compared to the HKA, the standard lines we draw. And what we found is they both correlated to the adductor moment and the Coos scores, but the moment arm was a better correlation. So maybe this is, when we don't do this routinely, but maybe this is a better way that we can measure the dynamic forces from a static image. Is there effect on the adjacent joints? Look at a lot of papers that people write. They say, well, we're worried about the effect on the hip, we're worried about the effect on the ankle. Well, that hasn't really been our experience clinically, so we looked at this in the gait lab, and we found that if you have an arthritic gait, you tend to walk on more flex joints. Post-operatively, this improves. So the motion in the sagittal plane improves and the joint reaction forces reduce. So again, this isn't necessarily going to happen to every patient, but this shows the potential secondary benefits of osteotomy on adjacent joints. So another example of things you can talk about with your patients. Okay, so the next question is, what alignment should we aim for? And if we look at it, there isn't really a consensus. You could walk around the room here, you could talk to experts, and you'll get slightly different answers that are all very similar, but maybe not exactly the same. And a lot of the research is based on very different things, sometimes long-term survival, sometimes PROMs, lateral cartilage wear, and then motion analysis. And if you look at our traditional recommendations, it's for an overcorrection. So you've got to overcorrect. Coventry, from the old days, we talk about up to 5 degrees of valgus. The Fujisawa point, which has been popularised at 62.5%, equates to about 2.5 degrees of valgus, but it depends on the patient's anatomy. And interestingly, if you go back to Fujisawa's original paper, he doesn't mention 62.5% at all. He talks about 30 to 40% of the lateral tibial plateau, which equates to about 65 to 70%. But it's just evolved through the literature that people have sort of decided that this is what the Fujisawa point is. Okay, so it's very interesting when you look back on original papers. So we simulated this with some FEA and some modelling of the knee joint, and we found that when you simulate the correction and model the forces across the joint, they tend to equalise at about 1.5 degrees of mechanical valgus. So that would support taking it a little bit further than that to offload the medial compartment, which is also supported by our gait studies and also supported by studies where we looked at articular cartilage recovery in the medial compartment post-osteotomy, and we saw this and published this, and over 1 year it stabilises, and at 2 years it actually improves. So you can actually, it's one of the few operations we do where you can affect the natural history of a condition. Joint line obliquity is a big thing in arthroplasty right now. Everybody's talking about it. Everybody knows about the CPAC classification, which has very proudly come out of Australia from one of our friends and colleagues. So we thought we should look at this, because we always change the obliquity when we do an osteotomy, obviously. And does that obliquity have an additional impact beyond your change in alignment? And the answer to that question is yes. And I won't go into all the details of this study, but we can measure the forces across the joint, as I said before, and we can model the effect of the alignment and also the obliquity. And what we found is that that joint line obliquity has an additional effect beyond the change in alignment. So it's an important thing to consider when you're planning your osteotomy, as I'll talk about later. But it's also a consideration for your revision knee replacement. You have an osteotomy like this before and you plan a standard cut. That makes the knee replacement quite difficult to balance. So this is sometimes we might look at different options rather than a single level osteotomy. Do we do it on the femur or the tibia? Well, we have to think about the site of deformity, the degree of correction, and the joint line. Typically, we'll do an HTO for a varus deformity. We'll do a DFO for a valgus deformity. But sometimes you might have to think a little bit outside the box. So if we look at this person, if they've got a valgus deformity, look at their tibia, it's actually quite valgus. So we can do the correction on the tibial side for these smaller corrections. And then if you have someone like this who has this weight-bearing line falling outside the joint, I think we're going to see a demonstration of this, then a double-level osteotomy is going to correct them but maintain that joint line. So the correction prescription really needs to be individualised depending on the pathology. Based on what we've done with our research and our experience, for established medial compartment arthritis, 2 to 3 degrees of mechanical valgus is about right. For early arthritis or chondral lesions, just really trying to offload that, so about 1 to 2 degrees of valgus. For instability, it's more of a neutral, just to offload those soft tissues. And lateral disease, we normally correct to neutral, because even when you're neutral, you're still slightly loading the medial compartment more, and avoid excess joint obliquity. So now we're going to move on to surgical technique. How do we achieve this correction? So we've decided who we're going to do it on, what correction we're going to aim for, and how are we going to do it. And we obviously need very precise tools. And I think osteotomy is one of those ones where orthopaedics surgeons look at it and they sort of correct it to what they think looks right. And as time has gone by, we've got more and more precise. So how do we achieve this? Well, we can do these preoperative calculations. This is actually quite good. So we don't actually always need fancy technology. I know a lot of people don't have access to that. So if you do good preoperative calculations, you're going to get pretty close to the mark. But we can improve it. And many years ago, we started using computer navigation. We used it for arthroplasty, and we used it for many years. And we published on it. We felt that navigation would improve our accuracy. We can look at the alignment through the full range of movement of the knee, not just on a full extension radiograph. And we can look at it in 2 planes. So this is why we started using navigation, and it became very routine. There's literature to support the use of navigation. And when we started using it, we obviously correlated it to our long leg films post-operatively, and we were happy that it gave us an accurate result. And we published on this. This has been our standard practice for about 15 years. But in more recent times, we transitioned to 3D printed custom guides. And as everybody knows, this is an image-based modality. It was well established in arthroplasty. And when it first came out, we published a couple of papers showing that it wasn't particularly accurate when they first started using it. But the techniques have actually been refined. And we think it can give us improved virtual planning. And that's probably the main advantage, in my opinion. And hopefully it's going to be equivalent to navigation. This is the questions we asked when we first started. And this isn't a new concept. This paper was published from Belgium 10 years ago. Companies were doing it 10 years ago. So it's not a new concept, but it's been refined a lot since that time. So we do our preoperative EOS scan. We get our alignment in 2 planes. It gives us our alignment parameters. And then these can go straight into this app where we can then just titrate how much correction we want in the coronal plane, either in degrees or percentage width of the tibial plateau. And then once we've done that, if we want to change the slope, we can flick across to the slope plane and we can change that as well. So we can do this virtual osteotomy. And then once we've done that and we're happy with it, then the engineers, who are much cleverer than we are, can then turn that from the CT scan into a virtual osteotomy, tell us the correction amount and the wedge size, and they can give us a plan. So we can turn up to the operating room knowing exactly what we're going to do in terms of what the osteotomy is going to look like, where our pins are going to be, how deep we're going to cut with the saw, how big the wedge is going to be at the front and at the back of the osteotomy. So we're just making things more precise. And so this is what it looks like in the operating room. And you can see here I've got the 3D printed guide and the navigation on. So when we first started using this, we didn't just assume it's going to be accurate. We thought we would test it out first. And this is what it looks like prior to the osteotomy, after the osteotomy. And we did 55 of these with navigation. And if we look at the correlation, it's very high. So it turns out that they are quite accurate, and we're quite happy to use them in isolation. And it's been published on in systematic reviews, again, showing that this technology is quite accurate for this purpose. And finally, I'd just like to talk about some supplementary tunes. So we did a study about 10 years ago because we saw cartilage improvements with just doing the osteotomy. So we thought, well, maybe if we add chondrocyte implant, we can get better cartilage regeneration. And somebody else in Australia had done a study, but without a control group. So they'd show good results if you add MACI. They didn't have a control group. And we had our control group from our previous study. So to summarise the findings of this, then sure, you get good results, and maybe in some patients you get good cartilage regeneration, but it really wasn't worth it at additional expense, more costs, more time, and it didn't get us a much better result. So now we're looking at stem cells, and this has been published, and maybe there's a role for them. There is some promising early results, and I can't give you any data on this at all because we only just started doing it, but this is that patient I showed you before. And so we take bone marrow from the iliac crest, we concentrate in a proprietary machine, and all of our patients get a preoperative MRI scan and an MRI scan at 1 year, 2 years, and 5 years. So we can follow these patients very closely. So I'll just finish with a few examples. This is that patient I showed before, severe varus deformity. So if we do our virtual, this is a 45-year-old male, again, in many countries, gets a joint replacement. He didn't want a joint replacement, he's very active, very fit. So if we plan it out just on the tibial side, you can see we get a 10-degree valgus on the tibia. That's unacceptable in terms of joint line obliquity, and a 26mm wedge. So okay, we do a double level correction. We plan it so the tibia is in neutral, the femur goes to 3 degrees of valgus. That gives us our overall arithmetic HKA of 3 degrees of valgus, and PSIs can be made for both of those. The plan is executed, and this is the patient. So they can actually get going. I'm surprised at how little morbidity these patients seem to have, and I know that Christian and Rag have been talking about this today, and they're doing an example later on, and I think their experience has been the same. And this is his gait analysis, and these are the forces. So you can see the huge ground reaction force on the one side, and the other side is going right through the middle of the joint. This is a patient who has a valgus deformity, so someone who lost their meniscus, developing lateral compartment arthritis, valgus alignment. So we want to do a meniscus transplant, but it's not a very favourable condition. The valgus is in the tibia. We do a closing wedge on the tibia, small correction, add that to a meniscal allograft. So we're taking care of the alignment, and the allograft is really just icing on the cake, I think. This is a patient who had a growth arrest deformity. You can see the deformity in the proximal tibia. We can take a scan of the other side as our template, and we can then plan our virtual osteotomy. We can make a PSI to do the tubercle cut, a PSI to do the osteotomy itself, and then a PSI to cut the allograft wedge that goes into the osteotomy, and it makes a somewhat complex procedure simple and predictable. And finally, this is someone who's got a very severe deformity. She's only 42 years of age, and she came with this severe deformity. Somebody's already done an osteotomy on the femur to try and correct the varus, and obviously it did not work. So she's got this multi-planar complex deformity, which would be a very, very, very difficult knee replacement. I think most people would agree. And she's only 42 years of age. So we felt if we correct her anatomy, she'll probably be improved, and there'll be a better foundation for a future knee replacement. So we made the femur straight with a closing wedge osteotomy, and then we plan out the tibial correction, which is very complex, a huge tibial slope, huge tibia varus, so a 20-degree correction in 2 planes. So you can see how we can model this, and then we use a PSI, and this was quite a difficult operation. Okay. And this is what she looks like before, this is what she looks like afterwards, and this is the joint. And again, it's not perfect, but it's congruent, the anatomy is restored. She's had a good result, and she will be much better placed for a knee replacement in the future. So in summary, again, I'd like to really thank you for your attention, allowing me to share this experience. And I think if we use the science and our follow-up and don't just rely on our intuition and our experience and our memories, then we can do a much better job of patient selection, preoperative assessment, alignment, prescription. This procedure should be easy, it should be accurate, it should be reproducible. It should include appropriate supplementary procedures if we have evidence for them, and allow an enhanced personalised recovery. We need to collect ongoing data. In Australia, we just set up an osteotomy registry about 3 or 4 years, and that's going to help us even further to decide the best way to go. So I'd like to thank you for your attention. Thank you for this incredible honour and all of the festivity around it. And I'd like to welcome you to Issaquah in Boston in June. Thank you.